Hello, my name is Quentin Broussard. I'm Assistant Professor of Clinical Sciences at California Health Sciences University, and today we will be discussing sedation and paralysis. The reason we're talking about sedation and paralysis today is because sedation and paralysis are seen in many different healthcare settings, particularly inpatient as well as procedurally in some outpatient surgical settings. The goal of this talk today is to expose you to the different sedation and paralytic agents that are available, as well as how they are used in practice. Our objectives today will be to list indications for sedation and paralysis, to define tools used to monitor sedation and paralysis, compare and contrast pharmacological agents used for sedation and paralysis, describe sequential administration of sedation and paralytics, because it is important which agent gets administered first and which agent gets administered second or third, as well as review evidence-based recommendations for sedation and paralysis. So we'll start off with the case. HP is a 62-year-old female presenting to the emergency department with shortness of breath. She was just diagnosed with congestive heart failure 2 months ago and has been eating out at McDonald's every day. Vitals upon presenting include blood pressure 128 over 62, respiratory rate 28, heart rate of 120, and oxygen saturation arterially of 89%. Past medical history is significant for end-stage renal disease or ESRD. As a result of her shortness of breath, she requires intubation and mechanical ventilation with the need for sedation and paralysis. And this acute respiratory failure is most likely due to her congestive heart failure or exacerbation. Which of the following medication sequences demonstrates proper sedation and paralysis for HP's intubation? Is it cisatracurium, then fentanyl, propofol, then dexmedetomidine, succinylcholine, then morphine, or midazolam, then rocuronium? Next question. After HP is intubated, HP requires continuous sedation. Which of the following is most appropriate first-line continuous sedation for HP? Is it dexmedetomidine, fentanyl, lorazepam, or morphine? And last case question. Which of the following is the most appropriate RASS goal for HP? Is it +2 to +4, 0 to +2, -2 to 0, or -3 to -5? So after we discuss the different agents for sedation and paralysis as well as the different monitoring, you should be able to answer each of these questions accurately and confidently. So we're actually going to break this talk up into two different sections, sedation as well as paralysis. The first part we'll talk about is sedation and the sedation agents. Just to give you a little bit of background with sedation, particularly in regards to agitation and anxiety, is relatively common in intensive care unit patients and even emergency room patients. And as a result of agitation and anxiety, patients may have negative consequences. So think about, say, if you were to have an anxiety attack, what would be the types of things that would happen? Well, you might become tachypnic, you might start breathing a little faster. And if you start breathing a little faster, your oxygen and carbon dioxide exchange isn't actually occurring properly. You may become hypoxic. And you may not be able to breathe properly or even function homeostatically like we're used to doing. And these are just two examples for indications for sedation particularly. But just to give you an idea, whenever you're having states such as agitation and anxiety, your health is compromised potentially as a result of a stress response. So what sedation does is it's actually helping to calm your stress response by essentially putting someone to sleep. And that's one of the ways I like to think about it. If you have agitation or anxiety, it's important to properly identify it and treat it first so that you can reduce the risk and incidence of negative consequences, or even stop them from happening completely, even though sometimes you may still have negative consequences happen as a result of agitation and anxiety. Sedation may be indicated in patients who have agitation or anxiety, particularly in the intensive care unit setting, but it can actually be in almost any setting. It can even be in the outpatient setting. Say if patients are getting outpatient surgical procedures done, say if the patient is coming to the emergency room with some kind of acute illness where they're highly anxious or have some type of anxiety, patients may be indicated for sedation in those cases as well. And there are a lot of different things that play a role in agitation and anxiety. We go to this diagram, which was actually taken from a review article in the New England Journal of Medicine. There's a triad that's known as the pain, agitation, and delirium triad, or the PAD triad. And as you see here with all these different arrows, these are essentially influences upon one another. So as you can see here with this middle triangle, pain can cause delirium, and which we'll talk about later in the semester. Delirium can cause agitation, and agitation can cause pain, and vice versa if you go in the other direction of the triangle. Another thing to take into account is that other things outside of this central triangle can cause pain, agitation, and delirium. The thing that we'll focus on mainly today is agitation. So things such as anxiety, frustration, lack of homeostasis, physical restraint if someone is not able to move properly or is physically restrained because they may be a danger to themselves. Inability to communicate, which we see a lot in a lot of our ICU patients who may be mechanically ventilated and have a tube down their throats. That can cause a significant degree of agitation, as well as when patients aren't able to breathe properly, or whenever we actually do put them on a mechanical ventilator and the mechanical ventilator is not matching up to how the patient should be breathing, and that's known essentially as ventilator dysynchrony. Essentially, the ventilator, it does not match up to the way that the patient is breathing, or essentially you're not getting enough of that oxygen delivery to the lungs such that homeostasis can occur. So it's important to keep in mind that there are many different causes of agitation, and agitation essentially is one of the things that can lead to patients needing sedation. In regards to sedation indications, one of the biggest indications for sedation is intubation. Intubation is essentially whenever we place what's called an endotracheal tube down the esophagus of a patient, terminating right before their lungs or even near their lungs, so that patients can actually breathe properly. And these are commonly instituted when patients are not able to breathe on their own. So think of things that may affect your lung function, things such as asthma, COPD, pneumonia, even simple things that we would think would be simple, like anxiety attacks. You know, each of us may have an anxiety attack. However, depending on the severity of that anxiety attack, patients may become relatively tachypnic or even hypopnic, not breathing at all. It just depends on the person. So intubation is a way to essentially assist a patient in breathing with the assistance of a machine called a mechanical ventilator, which is traditionally attached to the end of this endotracheal tube right here. So that's probably one of the biggest indications for sedation is intubation. Because think about it, if you have a tube down your throat, you will probably most likely be very agitated. However, whenever you actually weigh out the risk and the benefits of having the tube there are tremendous, because the tube is helping the patient to breathe and stay alive. However, the tube can cause a lot of pain, discomfort, and agitation. And that's why we sedate patients, so that a lot of that anxious and agitated response can be minimalized, because if that anxiousness and agitation continue, it can actually cause detrimental effects to the patient, such as acute respiratory failure or a worsening of present acute respiratory failure. Some other indications for sedation include pain, because as we saw in the previous triad, pain can make you very agitated. Delirium, which was another indication from that triad. Another common indication is hypoxemia or hypercapnia. And those are reasons for patients to be intubated. And if you are intubated, you most likely should at least be sedated on the front end. Eventually, patients may be able to tolerate not being on sedation while they're intubated, but mostly in the acute phase of the beginning, they'll probably need to be sedated, most likely continuously. Other things such as hypoglycemia, which can cause altered mental status, hypotension, alcohol withdrawal, which we'll actually talk about a little bit in this class with Dr. Wang, medication withdrawal, and that not only includes illicit medication withdrawal, it also includes regular medication withdrawal as well. An inability to communicate. So think about if you have a tube down your throat. You're probably not going to be able to speak on your own. And whenever patients and people are not able to communicate, people can get very agitated. Whenever patients do become agitated, they may actually require physical restraint. Physical restraint is something that you not only see in a psych setting, but it also may be seen in an intensive care unit setting or even a surgical setting, where we're having to restrain the patient to a bed so that they're not able to cause any harm to themselves. Because sometimes what may actually occur is these patients may actually start messing with some of the medical equipment that is attached to them, even this endotracheal tube. Sometimes we'll actually see patients pull on this endotracheal tube if they're not physically restrained. Now, not all patients need physical restraint. It depends on the level of agitation of the patient, as well as the physician preference. But if patients withdraw this endotracheal tube, they may risk having respiratory decline. As we mentioned earlier, surgery or other procedures may be a need for sedation, and particularly intermittent sedation, so they may only receive a few doses of sedation versus it being continuous on the outpatient side. Or you may have continuous sedation on the outpatient side or even on the inpatient side. It just depends on the type of procedure, how long the procedure is going to be, what exactly is going on in that procedure, etc. And there are many others. Think about anything that can influence that pain, agitation, and delirium triad that we showed previously, and you may actually have an indication for sedation. In terms of sedation monitoring, sedation can be titrated to either light levels, where the patient's able to be aroused and able to follow commands. So say if you were able to speak to them, they would be able to wake up, or if you touch them, they may be able to wake up, or to deeper levels, where it may take a lot more effort to wake a patient up, where that patient is essentially unarousable and unresponsive to painful stimuli, whether it be voice, touch, etc. In general, light sedation is preferred over heavy sedation in most cases. And if you think about it, it makes a little bit of sense once we start talking about the different agents, because a lot of these agents that we'll talk about have a lot of adverse effects associated with them. And these adverse effects can essentially accumulate or last longer when you sedate more. So ideally, a lighter level of sedation is preferred in most cases. The only exception to this, or one of the main exceptions to this, would be continuous paralysis, which we'll talk about a little bit later. There are two main monitoring tools for sedation, particularly in the intensive care unit or the emergency room, and those are known as the Richmond Agitation Sedation Scale, or the RASS scale, and the Riker Sedation Agitation Scale, or the SAS scale. And both of these scales are highly valid and recognized by the pain, agitation, and delirium guidelines to essentially make a subjective measure of sedation more objective. And we'll show you how each of these works. So the first one is the Richmond Agitation Sedation Scale, which is probably the more common of the two between the RASS and the SAS scale, depending on which institution that you're at. Some hospitals may use the RASS scale and some hospitals may use the SAS scale. And the Richmond Agitation Sedation Scale is based on a scale of -5 to +4. Essentially, a number of 0 indicates that the patient is alert and calm. Numbers below 0 indicate that the patient has some kind of level of sedation. And numbers above 0 indicate agitation, as we'll show you in this diagram on the next slide, which is here. So as we see here, alert and calm, as we mentioned, was 0. So this is an important number for you to remember. I don't expect you to necessarily remember each of the different descriptions with each of the different scores, but I would expect you to know that 0 is alert and calm. Anything below 0 is some level of sedation, with the lower levels being more deeply sedated, and the higher level scores being more agitated or combative, as well as the range of the scores. So ideally, we want patients alert and calm, or people in general alert and calm. However, patients may actually become a little bit more agitated or restless, and they may develop scores of +1, +2, +3, or +4, depending on if they have any factors in that pain, agitation, and delirium triad that we talked about earlier. And as a result, those may be indications for patients to be sedated. As you see here, some of the descriptions that we have here for +1 for restless, so maybe anxious but movements not aggressive or vigorous. Agitated, a score of 2. Frequent non-purposeful movement, fights ventilator, say if they were on the mechanical ventilator. A score of 3. Pulls or removes tubes or catheters, very aggressive. And +4 is combative. Overtly combative, violent, or immediate danger to staff, which you may see in some psych settings, but you also may see even potentially in an intensive care unit or an inpatient setting. So keep each of these different scores in mind. Again, the one thing I want you to emphasize is that scores greater than 0, agitation. Scores less than 0, sedation. As we see here, with a score of -1, you have drowsy, not fully alert, but has sustained awakening, eye-opening, or eye contact to voice for greater than 10 seconds. Whereas the lowest score, which is -5, no response to voice or physical stimulation. And this can happen as a result of multiple things, some being brain injury and whatnot, but also, and probably more commonly, this may actually be a result of oversedation. And we remember, as we talked about earlier, there may be more complications from oversedation versus a lower level of sedation where you're kind of remaining in this 0 to -2 level. So that is the RASS scale. The SAS scale is slightly a little different. Again, it's a valid and reliable scale that's endorsed by the pain, agitation, delirium guidelines. However, the scoring on this scale is different. So instead of the score being from -5 to +4, as we saw with the RAS. With the SAS scale, we're actually from a score of 1 to 7. Scores below 4 indicate sedation, scores above 4 indicate agitation, and 4 indicates essentially alert and calm. So if we look at the scale here, that alert and calm, or calm and cooperative level, is at 4 on the SAS scale, and that's important to remember. Calm, easily arousable, follows commands. The higher the level of the score, the more agitated the patient is. And you see the descriptions are just slightly a little bit different than the RAS scale. They're very, very similar, though, if you actually take a look and compare the different scores, versus the lower scores from 1 to 3, which may indicate sedation. Now, keep in mind that the description of these scores is a little bit subjective to an extent. Because some clinicians, as well as nurses, may interpret each of these scores slightly a little differently whenever you're actually trying to assess the score. And what I mean by that is saying, say if you were at a score of 5 on the SAS scale, anxious or physically agitated, calming adverbal instruction. Anxious or physical agitation can be a little bit subjective in measure, because it's kind of hard for us as humans to all be on the same page in regards to subjectivity. And anxious and physically agitated may be a little bit of a subjective measure. And that's why they try to write out these descriptions as best they can. Ideally, these are pretty sensitive and specific, meaning that most people will get a similar score whenever you compare different raters in terms of the score. So what I'm saying in that sense is that if someone rates a person a +5, more than likely another person will also rate that person a +5, or it may be a +6 or a +4. It's relatively close. But it's important to try to do your best whenever you're making these judgments, because these can actually affect the way that we dose sedation, as we'll talk about a little later. So that is the SAS scale. So it's important to realize the differences between the RAS and the SAS scales, and how they're similar and how they're different. Each of them has a middle point, the RAS being 0, the SAS being +4, and then they have levels of agitation and sedation below each of them. So it's important to be aware of that, as well as the ranges of the scores. Now we're going to actually move on to pharmacotherapy regarding sedation. And pharmacotherapy with sedation is pretty varied. You have different pharmacological classes that can play a role in sedation. There are opioids that we use, such as morphine, hydromorphone, or fentanyl. Benzodiazepines, such as lorazepam and midazolam. And then we have other sedative agents, such as propofol and dexmedetomidine or precedence, as well as etomidate and ketamine. The first class we'll talk about as a class is opioids, and we'll start with morphine. As we know, most of the opioids are mu antagonists in some way, form, or fashion, though there are some exceptions to that rule. And in terms of sedation and pain, morphine is available IV. Now, if you're trying to sedate someone, you're more likely to use an IV form of these medications than a PO. And I am aware that morphine, hydromorphone, and fentanyl do have some respective PO forms, whether it be as a tablet, buccally, or sublingually. But mostly for sedation purposes, we use IV. In terms of morphine specifically, onset's about 5 to 10 minutes, and intermittent dosing is between 2 to 4 milligrams every 1 to 2 hours. If you're going to do a continuous infusion of morphine, you'll want to do anywhere between 2 and 30 milligrams per hour, depending on the patient's need for sedation. Some important considerations with morphine is that it does have a significant level of histamine release. Whenever we think of opioids, morphine is pretty much one of the king of the opioid class. However, because of this significant histamine release, it can cause adverse effects such as hypotension, which may make it not preferable to use first line in sedation if you're using an opioid for sedation, which the other opioids will have different levels of histamine release, which we'll talk about shortly. Another consideration with morphine is that it does accumulate in hepatic and renal impairment. Hydromorphone differs a little bit from morphine. It is also used for IV for pain and sedation, and does have its respective PO forms as well. Onset is relatively short as well, 5 to 15 minutes. Intermittent dosing is anywhere from 0.2 to 0.6 milligrams every 1 to 2 hours. And if you're running a continuous infusion of this medication, the IV form ranges between 0.5 and 3 milligrams per hour. In comparison to morphine, it has less histamine release, meaning that you'll have less hypotension. And it may be a little more preferable to morphine for the use of sedation, though it's not the most preferred. And we'll talk about that next when we talk about fentanyl. Like morphine, it also accumulates in hepatic and renal impairment. Your workhorse in the ICU particularly is going to be fentanyl. Fentanyl, like the others, is a mu agonist and is available IV for pain and or sedation. Onset is relatively short as well, 1 to 2 minutes. The intermittent dosing of fentanyl per weight is 0.35 to 0.5 mics per kilo every 30 minutes to an hour. Though some people may use smaller doses and some may use slightly larger doses. If you look at how morphine is provided in the vial, it's provided as 25 and 50 mics traditionally. In some cases, you may have larger vials, such as the label here, where you get 250 mics per 5 mLs. I've seen clinicians use anywhere from 25 to 100 mics at a time as a bolus, because sometimes they may not use this weight-based dosing here. So just keep that in the back of your mind. In regards to sedation maintenance dose, per weight, it's 0.7 to 10 mics per kilo per hour. Though in some settings, you may not exceed 300 mics per hour. And obviously, considerations with fentanyl would be that you may have less histamine release compared to morphine and hydromorphone, which will actually make it the preferred opioid for use in continuous sedation. Because if we think about patients who are getting sedated, these sedative agents can cause significant amount of hypotension. And in the patient populations we use these in, some of these patients may already have hypotension or be prone to hypotension. So using agents that minimize the risk of hypotension is preferred, and fentanyl would be the preferred opioid for continuous sedation. Like morphine and hydromorphone, it does also accumulate in hepatic impairment, though it may not necessarily be a contraindication to using fentanyl. It does not accumulate highly in renal impairment. So those are essentially the opioid agents. The big thing to realize from this is that fentanyl is essentially the workhorse of the opioid class in terms of sedation, though the other agents can be used as well. Say if you have some kind of intolerance to fentanyl, or fentanyl can't be used for some reason. In addition, all of them have a risk of histamine release, which may actually cause hypotension. And all of the opioids also have risk of respiratory depression, which is another thing that is not on the slide, but it's important to know about. Which is why whenever patients are on continuous maintenance doses of these medications, it's important to properly ventilate these patients. The next class we'll talk about is benzodiazepine agents. And we'll only focus on really two of the most commonly used benzodiazepine agents used for sedation, and those are lorazepam and midazolam. The first one we'll talk about is lorazepam. The benzodiazepine agents are GABA agonists, so they will sedate through their action of GABA. They are traditionally administered either IV or IM for sedation, though IV is probably the most common route that you'll see. IM can also be used if IV access has not been established. In terms of lorazepam, traditional onset after loading dose is about 15 to 20 minutes, so some patients may sedate immediately after receiving lorazepam. The sedation loading dose is traditionally between 0.02 and 0.04 mg per kilo, which will traditionally amount to around 2 milligrams or less per loading dose, though you may actually give higher loading doses in some cases, like status epilepticus, which we'll talk about when we talk about status later on in a few weeks. Sedation maintenance dose between 0.02 and 0.06 mg per kg every 2 to 6 hours if you're doing intermittent dosing of lorazepam. One thing to keep in mind with lorazepam is it does have a longer half-life, so you may be able to get away with these intermittent maintenance doses, or you can also institute it as a continuous infusion of 0.01 to 0.1 milligrams per kilo per hour, not exceeding 10 milligrams per hour. Adverse effects of lorazepam and midazolam, the benzodiazepine class, as well as the opioid class, would be hypotension and respiratory depression. So it's important that if you're giving these agents continuously, you should probably have the patient on a mechanical ventilator. Some considerations specifically with lorazepam, it needs to be diluted 1-to-1 with saline. And the IV formulation contains a component known as propylene glycol, which is a solvent. This propylene glycol, when administered at high doses for long periods of time, can actually cause a metabolic acidosis, which is an anionic at metabolic acidosis, and hypotension as well. So that is one of the reasons that lorazepam can cause hypotension, in addition to the fact that it is a benzodiazepine agent. So that's an important fact to know about. The other benzodiazepine agent we'll talk about is midazolam reverse sed. It's also a GABA agonist, used IV or IM for sedation. Relatively short onset after loading dose, about 2 to 5 minutes, so a little shorter than lorazepam. Loading dose is traditionally 0.01 to 0.05 mg per kilo, and the maintenance dose is anywhere from 0.02 to 0.1 mg per kilo per hour. Adverse effects, same as lorazepam, hypotension, respiratory depression. One thing to note with midazolam is it does have a much shorter half-life than lorazepam, so it does rapidly redistribute. It does have an active metabolite, and it is renally eliminated. So if you have a patient who has end-stage renal disease, this may not be the agent of choice for that patient, as it can constantly reaccumulate or accumulate in the body, resulting in higher levels of sedation and higher risk of adverse effects such as the hypotension and respiratory depression that we just mentioned. So that is the benzodiazepine class. Now we'll talk about some other sedatives that are used commonly for sedation purposes. First one we'll talk about is propofol. And it's a GABA agonist and an NMDA antagonist. And if you remember NMDA, those are receptors that, when activated, are essentially excitatory. And it is believed potentially that propofol may be an NMDA antagonist. So if you're inhibiting excitatory receptors, you produce a sedative effect. Onset after loading dose is approximately 1 to 2 minutes after the dose. Sedation loading dose per minute is about 5 mics per kilo per minute over 5 minutes. Though some clinicians may use a commonly used dose of 1 to 2 milligrams per kilo of propofol, and may wait, a couple minutes if the patient isn't sedating properly, and that happens a lot in procedural sedations. Its sedation maintenance dose continuous infusion is anywhere between 5 to 15 mics per kilo per minute, and some hospitals will actually cap that out at 70 mics per kilo per minute, just for reference. Like a lot of our other sedative agents, adverse effects include hypotension and respiratory depression. Another big thing to realize with propofol is that there is a risk of what is called propofol-related infusion syndrome, or PRIS. And what essentially that can manifest as is if you are giving high doses of propofol for prolonged periods of time greater than 48 hours, you may see multi-organ failure occur, such as cardiac failure. You may see rhabdomyolysis and metabolic acidosis, and these complications can be potentially fatal. So if a patient is on propofol, it's important to maintain the lowest dose needed for sedation, but also to keep in mind that you should not be ideally on propofol for too long, as it does have this risk of propofol-related infusion syndrome, which can be fatal. Some other considerations is that it does require mechanical ventilation, like most continuous sedatives do, and it is contained as a lipid emulsion, which contains 1.1 kilocalories per mil. And this will be important whenever we talk about nutrition support, because a lot of patients who receive nutrition support also may be receiving sedation as well. As a result of it being contained in lipid emulsion, it may raise your lipid levels, particularly triglycerides. And in some cases, you may actually hold propofol if your triglyceride level exceeds certain amounts. Another continuous sedative that's commonly used now is Precedex. And Precedex, or dexmedetomidine, is a newer sedative, probably within the last decade or so. It's an alpha-2 agonist, so it actually works similar to clonidine. If you want to think of it as IV clonidine, you potentially can, because they do act the same way. Onset after loading dose is about 5 to 10 minutes, and the loading dose is about 1 mic per kilo over 10 minutes, though this loading dose won't always be given. Typical sedation maintenance dose is anywhere from 0.2 mics per kilo per hour to 0.7 mics per kilo per hour. The one thing I do want you to realize about this dose is that it is in mics per kilo per hour. It's one of the few agents that actually is dosed in mics per kilo per hour. It's not dosed in mics per kilo per minute. That would obviously result in a significant overdose, so please be aware of this unit here. Adverse effects that can occur as a result of dexmedetomidine is that it can cause hypotension, like many of the other sedatives, or it can actually initially cause hypertension, particularly with the bolus doses, and usually this is a compensation response. Dexmedetomidine can also cause bradycardia. One important thing about Precedex or dexmedetomidine that makes it different than most other sedatives is that it does not cause significant respiratory depression. As a result of this, It can be used in mechanically ventilated or non-mechanically ventilated patients. So your patient, if they are on precedence, does not need to be on the vent to be on precedence. That is a very important concept that not everyone knows about, because it does not cause that significant respiratory depression the other sedatives do. Now we're going to transition a little bit, and we're going to talk about etomidate. Etomidate's a lot of bit different than dexmedetomidine and propofol, which we just talked about in the other sedatives section. It is a GABA agonist, similar to a lot of the other sedatives, and it has what makes it different than the other ones is it has a short onset of action and a short duration of action. And with this agent, continuous infusion is not routinely done, because this agent's most commonly used in rapid sequence intubation, and it redistributes rapidly. So they will actually be given as bolus doses right before a paralytic is given, commonly for rapid sequence intubation. The bolus dose is anywhere between 0.2 and 0.6 mg per kilo over 30 to 60 seconds, and the duration of action, like we said, is relatively short. So if you want to just sedate your patient for a short amount of time, such as the time needed to stick an endotracheal tube down someone's throat via the physician, then etomidate would probably be your drug of choice for rapid sequence intubation. Though, you can almost use any of the other sedatives for rapid sequence intubation as well. It just depends on the prescriber's preference. But the main thing that I want you to get from this agent is it is mainly used for rapid sequence intubation, and it is not done as a continuous infusion versus a lot of the other agents which are. Ketamine is also different. Ketamine is not routinely used often for continuous sedation, but it is used more so for procedural sedation, though it can still be used for continuous sedation. It is an etomidate receptor antagonist, so again, working on the excitatory receptor, or basically antagonizing those excitatory receptors, producing potential sedation. The onset of action IV is within 30 seconds, and duration is about 5 to 10 minutes. It can be given as a loading dose, and you have a sedation maintenance dose here. There are many different reasons that you would use ketamine, one of them being status epilepticus, which we'll talk about in a couple of weeks, the use of ketamine there. Ketamine does have a lot of issues with it. Number one, it is in some realms considered an anesthetic and most likely should be just reserved to the surgery setting, though it may be potentially used in other settings. It also has some nasty adverse effects associated with it, such as psychosis, neurotoxicity or neuronal loss, as well as hypertension or hypotension. If you're giving it continuous infusion, you should be mechanically ventilated, because it is considered in some realms to be a full-on anesthetic agent, and most people will only reserve it for use during intensive surgery. Though it can be used procedurally, and I've seen that actually done many times, either by itself or in combination with other sedatives. Another thing is that it does increase intracranial pressure. So whenever we talk about traumatic brain injury shortly, we'll actually have to keep this in mind, because if we're sedating patients, ketamine may not be the best choice for patients who have traumatic brain injury. Another thing with ketamine is it may be used off-label for analgesia versus the other, or most of the other sedatives, which don't necessarily have analgesic properties themselves, though may be analgesic sparing. So now that we've talked about most of the sedative agents that are out there, now let's go to the pain, agitation, and delirium guidelines to see what they actually say regarding sedation. These guidelines were published in 2013. Reference is right here. and is also included on CAMS, posted as a PDF. So regarding the guidelines say that quality and sedation depth should be routinely monitored. And that's a positive 1B recommendation. As we talked about earlier, lighter levels of sedation are associated with improved clinical outcomes. And these can be outcomes such as shorter ICU length of stay or shorter length of mechanical ventilation. That's also a positive 1B recommendation. So in terms of the goal of what lighter sedation is for the RASS and the SAS scales, a goal RASS of -2 to 0 for light sedation and a goal SAS of 3 to 4 for light sedation are what are considered light sedation. So whenever you're at -3 or below for the RASS scale, or at 1 or 2 for the SAS scale, those are considered deep sedation. So these are essentially your goal RASS and SAS for light levels of sedation. Now remember, you don't want to do light sedation in the case of continuous paralysis, because if you have a patient who's paralyzed, one of the worst things that you can do is have them paralyzed and awake. It will actually terrify them. So in those cases, deeper RASS and SAS goals may be needed. In terms of what agent do you use first for sedation, particularly continuous sedation, analgesia first sedation, or what's also known as analogous sedation or A1 sedation, should be done first in mechanically ventilated patients. And that's a positive 2B recommendation. That's not as good as the other recommendations we just talked about. And we said earlier that fentanyl is preferred because it has less histamine release, less risk of hypotension, less risk of respiratory depression, though remember those things can still happen. So what do you do if you use fentanyl or another opioid, for example, and you titrate that opioid to its maximal dose and you don't get adequate sedation out of that in your goal of your RASS of 0 to -2, for example? Then you might go on to the other sedative agents that are given continuously. And what the guidelines say regarding these agents is that non-benzodiazepine-based sedation is preferred after analgesia for sedation, instead of using benzodiazepine-based sedation. So what this statement says is that after you use fentanyl, and it's maximally titrated ideally, though in some cases clinicians may not necessarily do that, then in those cases you'll want to go on to a non-benzodiazepine agent. And those agents are propofol and dexmedetomidine or precedence. The exception to this rule, where you would not want to use benzodiazepines, is alcohol withdrawal, benzodiazepine withdrawal, illicit drug withdrawal, or status epilepticus. In those cases, benzodiazepines are preferred. The reason we don't use benzodiazepines in general is that they do have a lot of deleterious side effects and adverse effects associated with them, one of them being ICU delirium. And we'll talk about that more whenever we talk about delirium later in the semester. But in those cases where we have patients who are delirious and they're not for one of these exception reasons, we should use propofol precedence first. If we have one of these disease states where we actually need strong GABA agonism to counteract these different disease states or minimize these different disease states that you see here, then we would need a benzodiazepine first. And again, we'll talk about that later whenever we talk about these different disease states throughout the semester. In general, sedation protocols and checklists should be used to facilitate sedation. And that's a positive 1B recommendation. If you have patients who have agitation, such as a RASS score of 1 to 4 or a SAS of 5 to 7, you may consider increasing the sedation dose. If your sedation dose is too heavy, such as a RASS of -3 to -5 or a SAS of 1 or 2, you may consider decreasing the sedation dose if you're too sedated. Again, the exception is continuous paralysis. And then we may actually want to institute what are called sedation holidays if applicable. And those essentially mean stopping sedation to try to essentially wake patients up if we can. There may be some preclusions to doing this, such as obviously continuous paralysis, but also if they're on high levels of vent settings where they are very needy on the mechanical ventilator for oxygen, we may not institute sedation holidays. Two terms that you may hear whenever you go out into practice and if you go on your acute care rotations are spontaneous awakening trial and spontaneous breathing trial. Essentially what this is spontaneous awakening trial is that they'll lower the sedation level on the patients to try to wake them up. So that may be lowering it by, anywhere from 25% to completely turning it off if it is a low level of sedation, just to try to wake patients up. Because if patients are on sedation for long periods of time and sedation starts to accumulate, patients, again, may have a longer length of stay and a higher risk of complications during their hospital stay. So it's important to keep light levels of sedation while in the hospital. So that's essentially what a spontaneous awakening trial is for. Spontaneous breathing trial is once you lower sedation, if the patient is on sedation, what you can do is have the patient breathe on their own if they're mechanically ventilated at not a high setting. So at this point, the patient may have the ventilator weaned to a different setting or actually turned off to see if they can breathe on their own. And a doctor or a respiratory therapist will watch the patient to see whether or not the patient can be able to breathe on their own and handle breathing on their own. If they're not able to breathe on their own, then they will be put back on that vent setting that they were potentially previously on and may be resedated. This is just a little bigger version of that protocol or an example protocol that was on the previous slide. So if you see here, you have a patient who's greater than 18 years old and has a mechanical ventilation requirement. So they say start IV continuous sedation with fentanyl. And then their goal SAS here is between 3 and 4. So remember, we want to keep them lightly sedated. And then you evaluate again later on. And then if your SAS is too deep, like 1 or 2, you may decrease the infusion level. If the SAS is 3 or 4, you may keep or maintain that infusion level. And then if the SAS is higher, you may need additional medical evaluation and additional medication, such as propofol or precedence if they're maximally titrated out on their other sedative agents. So this is just an example of one protocol that one institution uses. Every institution will have a different protocol. And it's important to be aware of what that protocol is depending on what institution you work at. So now we're going to switch gears a little bit from sedation, and now we're going to talk about paralysis. To give you a little background on paralysis, about 13 to 90% of mechanically ventilated patients at some time during their hospital stay receive a neuromuscular blocking agent, or NMBA, for paralysis. And these NMBAs can be used for different reasons. So one of the main reasons that we would want to use paralysis is to facilitate some disease state obviously getting better, or even facilitate some process to be a little bit easier. One of the big things that we use paralysis for is to try to facilitate breathing in some cases, improve chest wall compliance, eliminate ventilator dysynchrony. So sometimes patients may be breathing over the ventilator as a result of a stress response, so they still may be agitated or anxious. And what paralysis does essentially is it kind of calms down those muscle responses so that we can actually facilitate breathing a little bit easier. It may reduce intra-abdominal pressures. One of the big things that paralysis can be used for is preventing or minimizing shivering. So if you think about paralysis is essentially a stiffening or a stopping of fasciculation of muscle. One of the things that may happen after cardiac arrest is that we may put patients under what we call therapeutic hypothermia. And what therapeutic hypothermia is essentially a cooling of the body to try to minimize neurological damage after cardiac arrest. And whenever we try to lower their body temperature, they may shiver. But remember, we're trying to lower their body temperature as a benefit to their neuro function. So paralysis may be given to potentially minimize this shivering that occurs. And it may also help to prevent elevations of intracranial pressure from airway stimulation, which we'll talk more about intracranial pressure whenever we actually discuss traumatic brain injury. Okay, to give you an idea of how paralysis works, we have to understand basic concepts such as action potentials as well as synapses. So whenever you have an action potential occur, remember action potentials include, in most neurons, an influx of sodium ions and an exiting of potassium ions. When this action potential occurs, what will happen is acetylcholine from these little vesicles here will be released into the synapse. And whenever acetylcholine is released into the synapse, it can go and bind to acetylcholine receptors such as nicotinic or muscarinic acetylcholine receptors on muscle to eventually activate that muscle to contract or to work in whatever way it wants to work. One thing to realize in paralysis is that we don't want this contraction to occur because this contraction may be a little bit detrimental to what we actually want to accomplish. So what neuromuscular blocking agents do is they will actually bind to these acetylcholine receptors here and antagonize these acetylcholine receptors, preventing acetylcholine from actually working on the receptors, preventing muscle from being activated. So that's the main important concept, is that the medications that we're going to talk about in this talk mainly act here on this acetylcholine receptor. Now that we have a little bit of background into what paralysis actually is, let's talk a little more specifically in terms of what indications for paralysis are. So the main indication, and probably the most utilized indication for paralysis, is emergency intubation. And this is traditionally done whenever an endotracheal tube is placed down the esophagus, as we talked about earlier with sedation. It may be important to paralyze patients whenever we're doing intubations, because say if we sedate someone first, and we always want to sedate before we paralyze. That is a given. After we sedate someone, and we're trying to stick this endotracheal tube in into this patient's esophagus, essentially. What may happen is that you may have a little bit of barrier issues, or you may have some muscle contraction issues that prevent this endotracheal tube from going down properly. So what we do with paralysis is that we'll give a short-acting paralytic, which we'll talk about shortly, to a patient right before they get this endotracheal tube put down their throat while they're sedated. And essentially what that paralytic agent is doing is helping to facilitate the placement of this tube. Because remember, muscle can, potentially obstruct this tube. It essentially helps that muscle to relax so that this tube can get down properly. Other indications, particularly with the lungs that we use paralysis for, acute lung injury or ARDS. This commonly happens as a result of sepsis, if you remember back from patient care 2. And what this essentially does is think about patients who have major stress responses that are causing them to become hypoxic, hypercapnic, and develop acute respiratory failure. If you continue having those stresses, a lot of those stresses are mediated by muscle, right? We have stress, it causes muscles to contract. Those muscle contractions may contribute to stress. And this is essentially a bigger picture way of looking at this versus a mechanistic picture. What paralysis can do in terms of acute lung injury and acute respiratory failure, and even status asthmaticus, because status asthmaticus is kind of more or less a subset of acute respiratory failure in general, is that it will help facilitate those lungs to help them breathe a little bit more normally without the worry of having additional stressors placed on them, such as, different stresses that different muscles in the body can have, such that it's causing things like tachypnea and whatnot. Paralysis can also help with elevated intracranial pressure, which we'll talk about elevated intracranial pressure a little later whenever we talk about TBI. And then again, therapeutic hypothermia after cardiac arrest. And the reason paralysis is used in that case is mainly just to prevent shivering, because remember, as we mentioned, hypothermia can help minimize neurological deficits after cardiac arrest, though it's not always foolproof. Paralysis is just used to prevent shivering from occurring. That will actually increase the body temperature. There are a couple of main ways that we monitor paralysis using what we call peripheral nerve stimulation. One of these is called the train of 4, and that's the most commonly used one. The other one that I've actually never heard of, or I've never actually done, is a accelomyography, which you actually see here on the right here. But for our purposes, we're just going to mainly talk about train of 4, because that's probably the most common one that you may see in practice if you encounter any kind of continuous paralysis. So, train of 4, as we said, is the primary qualitative measure of paralysis. And what is done in train of 4 is that you're essentially attached to electrodes, and these electrodes are applied to the ulnar, fascial, or posterior tibial nerves, which you can see these electrodes are attached here on the patient's arm. And after those these little attachments are placed, 4 electrical impulses will go through every half a second. Now, whenever you're paralyzing someone, remember, you want the muscle to either be depressed and not functional, or less functional than it was before. So depending on what your goal is for paralysis, and different physicians will have different goals for what they want for paralysis. you may consider adjusting the dose of paralysis depending on how many twitches you see out of those 4 twitches that happen. So, this statement here is if so many twitches happen, or so many twitches are present, where that blank again is a number. So if 0 twitches happen, that essentially means that you're paralyzed probably too much. We don't want patients to be over-paralyzed, but we also don't want them to be under-paralyzed either. Because if no muscles are working in the body, we can't function at all. Because we still have to have things like our lungs working, and there are certain organ muscles that still have to function to an extent. Those muscles can still function to a capacity, but whenever you're too deeply paralyzed, you may have too much depression of those functions. So if you have 0 twitches present, aka a TOF or train of 4 of 0, patient may be too paralyzed, and those may be cases where you may consider decreasing a paralytic dose. If you have anywhere from 1 to 3 twitches, the paralysis may be appropriate, and it depends on how many twitches your goal is. Say if your twitch goal is a TOF of 2, and you only have 1 twitch, you may consider decreasing the paralytic dose in that case. But if your goal is between 1 and 3, and you have 1 to 3, it may be appropriate. Now, if you have 4 twitches, for example, and if we actually think about people like us who are most likely not paralyzed at this time, most normal people would have 4 twitches if they were not paralyzed and they were hooked up to this train of 4 machine. So if a patient who is on paralysis has 4 twitches, it means that they're probably not paralyzed enough, and that you should consider increasing the paralytic dose. And again, it just depends on what the physician's goal is in terms of the paralysis. Remember, this is only used for continuous paralysis for the most part. It can be used for other shorter term paralysis methods as well. So essentially, like we talked about, this is what it looks like. And this is kind of an idea of what the different responses would be. I don't want you to be too focused on what these little bars look like here or any of this like diagram here. I just want you to be focused on if so many twitches occur, what does that mean? And what should you do with the dose of the paralytic? So now we're going to talk about the paralytic agents. And we're going to primarily focus on a few main paralytic agents. So paralytic agents are mainly broken up into depolarizing NMDAs and non-depolarizing NMDAs. There's only one depolarizing NMDA, and that's acetylcholine. That's probably one of the main neuromuscular blocking agents that we actually use. The other main neuromuscular blocking agents that I've seen personally in practice are cis-atracurium and rocuronium. It doesn't mean that the other ones aren't used. Atracurium is not used because it has a significant amount of histamine release, which we'll talk about in a little bit. But for the purposes of this talk, I just want y'all to get an exposure to the main paralytics that are used, and then be aware of the other paralytics that are used and some of the kinetics that are associated with those paralytics. So whenever we talk about these agents, we'll focus on the main things that we need to know. So succinylcholine, as we said, is a depolarizing NMDA. So what a depolarizing NMDA is versus a non-depolarizing is that it will actually bind to those acetylcholine receptors that we talked about more strongly than a non-depolarizing NMDA, which may be a competitive antagonist of the acetylcholine receptor. Succinylcholine is important because it is short-acting. Its time to maximal blockade or paralysis is less than a minute after it's given, and its duration is about 5 to 10 minutes. The bolus dose of succinylcholine is traditionally around 1 milligram per kilo. And because it is so short-acting, continuous infusion of this agent is not traditionally done. It's actually mostly manufactured as intermittent doses or vials or syringes. So it's important to know that it is not continuous infusion. Some considerations for succinylcholine. It's a paralytic of choice for emergent intubation in most cases, unless you have a contraindication or a caution. Some of the cautions is that you may have a caution in renal failure or patients that have hyperkalemia. And if you think about it, it makes sense. Because succinylcholine is a depolarizing NMDA. If you're antagonizing that acetylcholine receptor so much with succinylcholine, you're depolarizing different areas, that can actually cause increased release of potassium from cells. And as a result of that increased release of potassium from cells, hyperkalemia can result. It's also important that it's cautioned in renal failure, because patients who have renal failure may become very hyperkalemic as a result of accumulation. So patients who have renal failure or hyperkalemia may not be the best candidates for succinylcholine. It's also contraindicated in trauma. So if you think about trauma, for example, if you have some kind of traumatic accident occur or some kind of trauma occur where you are compressing and potentially breaking down cells, release of potassium will already most likely be occurring in those trauma situations, even if a potassium level is normal in the body. That's why it's contraindicated in trauma, because in trauma, cells essentially are broken down or destroyed. Another thing with succinylcholine is it may increase intracranial pressure or intraocular pressure. So it may not be the best agent to use in patients who have traumatic brain injury or even glaucoma for intraocular pressure. And it may increase the risk of malignant hyperthermia, which is an important thing to be aware about, because malignant hyperthermia is a medical emergency. So that is succinylcholine. It is a depolarizing NMDA, so it will bind to that acetylcholine receptor, antagonize it, and basically finish out that last action potential and get a lot of potassium, causing hyperkalemia. So don't use it in patients that have hyperkalemia, ICP or IOP increases, renal failure, or a history of malignant hyperthermia. Rocuronium is another commonly used paralytic agent. It's intermediate acting. Time to oxidative blockade is 1 to 2 minutes. Duration of action can range anywhere between 20 and 80 minutes, depending on the kind of dose that you give. The bolus dose is between 0.6 and 1 mg per kg. 1 to 1.2 mg per kg for rapid sequence intubation. So this is another agent that can be used for rapid sequence intubation. It can be used for continuous infusion, though this is not routinely done. It's most of its utility comes from the fact that it can be used in rapid sequence intubation, but it is possible that it can be used in continuous infusion as well. So its consideration is that it's an alternative to succinylcholine for rapid sequence intubation with succinylcholine is contraindicated, such as the cases where we had end-stage renal disease, hyperkalemia, increased ICP or IOP, or malignant hyperthermia. Probably the most commonly used continuous paralytic is cis-atracurium or Nimbex. and it's a non-depolarizing NMDA, similar to rocuronium. And non-depolarizing just means it's a competitive antagonist of that acetylcholine receptor. It's intermediate acting, such that the time to maximal blockade is about 2 to 3 minutes. The duration of action is about 30 to 60 minutes. So intermediate acting, similar to rocuronium. Bolus dose and continuous infusion dose are provided here. So its main considerations: commonly used as a continuous infusion. So if you have patients who need continuous paralysis, such as patients who have acute lung injury, ARDS, acute respiratory distress syndrome, if they need therapeutic hypothermia after cardiac arrest, or have status asthmaticus, this is probably the drug of choice. One of the big reasons this is the drug of choice is that it's mainly eliminated via Hoffman elimination. And what Hoffman elimination is that it's not being eliminated via the liver or the kidney. It's actually a non-enzymatic degradation of the drug in the body. And atracurium also goes through the same process, producing londazine metabolite. And again, paralytic of choice for continuous infusion for the most part, though other agents can also be used. But particularly paralytic of choice whenever both renal and hepatic failure are present, because it does go through this Hoffman elimination. It doesn't get eliminated renally or hepatically. So succinylcholine, rocuronium, and cisatracurium are probably your three big go-tos whenever you talk about paralytics, though there are some other paralytics that do exist, as we see here, such as pancuronium, vecuronium, and atracurium. And the main things that I want you to realize from these agents, though we did not go through each of the individual agents, what you see in red is what I want you to essentially know. So I would expect that you would know that pancuronium is a longer acting paralytic compared to succinylcholine, which is short. And then the rest of these in the middle are essentially intermediate acting. I want you to be aware about what kind of elimination these medications go through. And I'm not necessarily concerned about the percentage. I'm more concerned about the route that they actually go through. So as you see, most of them on this left side here are both renal and hepatic elimination. So they would not be preferred in renal or hepatic impairment. Cisatracurium, we said, is mainly Hoffman elimination. And that's why it can be used in renal and hepatic impairment, despite the fact that it is 5 to 10% renally eliminated. Atracurium is not used much anymore because it has this laudanazine metabolite, as well as cisatracurium, more so with atracurium, however. And that laudanazine metabolite can actually lower the seizure threshold. But another big thing with atracurium is that it has a significant amount of histamine release, and if you remember histamine release from morphine and hydromorphone, that may cause significant hypotension as well. So the things in red are the things that I want you to know from this chart. I don't want you necessarily to be concerned about the dosing of these medications. I do want you to know, however, if they're short, intermediate, or long-acting, the route of elimination that it goes through. And then I want you to be at least aware of the reasons that we don't use atracurium, which is the laudanazine metabolite as well as the histamine release here. In general, complications of paralysis. This can occur from any of the paralytic agents that are used. Include ICU-acquired weakness. And essentially what that means is that because you're paralyzing someone for so long, they're not moving for long periods of time. As a result, they may develop weakness as a result of protein-calorie malusage. So they're not essentially moving around. Think about it like this. if you had a person who was a bodybuilder stop working out for about a month, they would lose a significant amount of muscle mass, right? Well, this is kind of the same concept in that if you have patients who are not moving around a lot, like a lot of ICU patients do, which they do not traditionally move around a lot in some cases, you may develop ICU-acquired weakness. And that ICU-acquired weakness is even worse whenever you're on paralysis, because paralysis, you can't move at all. You may actually develop DVT from paralysis as a result of being static and staying in one place for long periods of time. That's why it's important that you utilize mechanical and/or prophylaxis when not contraindicated. So things like SCDs, compression stockings, heparin or Lovenox, if you can give heparin or Lovenox to your patient as long as they don't have a high bleeding risk, those should be done. Another big thing with paralysis is that continuous paralysis can actually cause corneal abrasions. And if you think about it, if you're paralyzed, the blinking reflex kind of goes away or is diminished significantly, resulting in the eye not being able to blink as much and not being able to get as much moisture. Therefore, it's important to utilize things such as artificial ointments, eye covers, or even methylcellulose drops to hydrate the eye. Anaphylaxis can also occur as a result of paralysis, which is similar to a lot of other medications, particularly with paralysis. It's IgE mediated. And one of the biggest things to be aware about with paralysis is awareness. Traditionally, we do not want patients to be aware that they are paralyzed because it can be very terrifying to them. So we may sedate the patients to deeper levels than the light sedation we talked about before. So a RASS of -3 or less, so -3 to -5, may be appropriate for patients who are paralyzed, or a SAS of 1 or 2 may be appropriate, versus in other cases where we want lighter levels of sedation to minimize complications. Here, if the patients wake up and they're paralyzed, they may develop different psychological disorders such as post-traumatic stress, which may need to be treated long-term and is more risky than the benefits that are allotted. So, that being said, in terms of sedation and paralysis administration, it's always important, if you're going to paralyze someone for any reason, that you always administer a sedative agent first before the paralytic. Never paralyze someone who is not sedated. And some people say that this is the most terrifying thing that could ever happen to someone because it can cause long-standing psychological problems. Here are the references for the talk today. And we'll go over the case questions from the beginning. So we had HP, 62-year-old female, came to the ED with shortness of breath, was just diagnosed with CHF 2 months ago and had been eating out at McDonald's every day, probably had a lot of salt intake and had a lot of significant fluid accumulation. Vitals included BP 128 over 62, respiratory rate of 28, heart rate 120, oxygen saturation 89. Past medical history of ESRD. She requires intubation and mechanical ventilation with need for sedation and paralysis due to acute respiratory failure as a result of probably a heart failure exacerbation. Which of the following medication sequences demonstrates proper sedation and paralysis for HP's intubation? The answer to this question is going to be midazolam, then rocuronium. The reason why, if you go through the other answers, cisatracurium, then fentanyl. So this breaks the rule we just talked about having a paralytic before sedative. Remember, paralyzing someone before you sedate them is probably the most terrifying thing you can ever do. So that answer is wrong. Propofol and dexmedetomidine. Propofol and dexmedetomidine are both sedatives, and the question asks for proper sedation and paralysis. So this answer is wrong because you did not actually paralyze the patient. Succinylcholine and then morphine. Again, the same issue as the first answer in that succinylcholine, the paralytic, was given before the sedation agent morphine. Another issue with this choice is that this patient has a history of end-stage renal disease. And if you're a depolarizing neuromuscular blocking agent like succinylcholine, you can actually increase the release of high potassium upon initial dosage of that succinylcholine, releasing that into the serum. And that can be a danger in terms of ESRD patients who accumulate potassium very frequently. And that high level of potassium can cause cardiac arrest if high enough. So, 2 reasons why this answer is wrong. So the answer here is midazolam than rocuronium. Rocuronium, we said, is not depolarizing, so it is not a concern necessarily as much in ESRD. Though remember, it will still accumulate a little bit in ESRD. It's not as much of an issue. And then midazolam is obviously used for sedative. So sedative, then paralytic. The next question. After intubation, HP requires continuous sedation. Which of the following is most appropriate first-line continuous sedation for HP? Answer here is fentanyl. The reason why is that we're doing analgesia for sedation. So we're using an analgesic, ideally, that has the most minimal amount of histamine release, and that is fentanyl. Fentanyl, again, is our workhorse. Dexmedetomidine would not be appropriate for this patient first because this patient has not undergone analgesia first. As long as this patient receives analgesia first as first-line continuous sedation, and if they're not sedated after that point, then you can use dexmedetomidine or Precedex. Lorazepam is not correct because remember, with exception of the exceptions like alcohol withdrawal, illicit drug use, or status epilepticus, for example, lorazepam should not be used first line because of its deleterious adverse effects. And then morphine is probably not the best option of these 4, particularly compared to fentanyl, because morphine may cause adverse effects as a result of its histamine release, such as hypotension. And the last question, which of the following is the most appropriate RASS score for HP? The answer here is going to be -2 to 0. So remember, we want light levels of sedation, which for the RASS score is between -2 to 0, or for the SAS score, it's 3 to 4. Anything in the positive areas indicates agitation, so +2 to +4 and 0 to +2 would be incorrect. -3 to -5 is also incorrect because that would indicate that the patient is too sedated, and the patient does not have an indication to be deeply sedated like continuous paralytic use. That would be needed for a continuous paralytic such as a cis-atrocurium drip. If you have any questions regarding this presentation today, please let me know, and have a great day.